Can you hear me, Nitin? Is it audible?
Yes, yes.
Can you see my screen now?
Yes.
Yeah, okay. Good evening, everyone. Sorry for some inconvenience in the Zoom and also by my last week technical glitches. I'll have a quick recap if you have attended the last session. Might be first few slides might be the similar ones what we have discussed before. So as I said, like we're going to talk about basics of ventilation and some modes of ventilation physiology, particularly in relation to neonatal. So just quickly, the ventilation, the main purpose is oxygenation, which means oxygen going into from the lungs into the bloodstream, and ventilation, which mainly means exhalation of the carbon dioxide. Okay, so if you can divide the physiology into two parts, the inspiration and the expiration. The inspiration is an active process, mainly starts with the negative pressure developed in the intrathoracic cage, mainly by the relaxation of intercostal muscles and the diaphragm. The main difference from the neonates to the adults is the neonatal chest is more cylindrical, the ribs are more horizontal. So by just having changes in the muscles, intercostal muscles and diaphragm, there is not much negative pressure that is generated in the neonates compared to pediatric and adult age group. And also the intercostal muscles and diaphragm are not very strong and not very stiff to provide a negative pressure that is sufficient enough to provide inspiration. So because of this, if there is any lung pathology, because the intercostal muscles and the diaphragm as a whole, an active process of inspiration is not helping the baby to breathe effectively, the lung pathology makes it more difficult for the baby to breathe. And also, and if it gets unsupported, the lungs get unsupported, the baby goes into fatigue. That's the main physiology behind it. Going to the expiration side of it, expiration is a passive process. It happens because of the elastic recoil. Elastic recoil happens because of surface tension. As we all know, like surface tension is a tension that pulls the lung back into the collapse stage. Okay, the more the surface tension, the more risk of collapsing. The deflation of the lungs happens. So in the preterm babies and specifically the RDS babies, because of surfactant deficiency, the surface tension is very high because of the absence of surfactant. That causes elastic recoil much difficult. And also the secretions, because of inability to swallow and inability to clear the secretions themselves in the preterm babies particularly, they have more secretions that causing the expiration of the air out is making it difficult, causing air trapping. This is the most common thing that we see. So inspiration, because not much support from the intercostal muscles and the diaphragm, and the expiration mainly because of the pathophysiology, mainly in the preterm babies and also in secretions. So just a few words, probably we discussed it last week as well. I just want to reiterate the points again before we move on. The factors affecting ventilation when you are discussing about physiology, and also when you are trying to set up a ventilation mode for a baby, which mode of ventilation is good for this particular baby, is the 5 things which we need to look at. One is the compliance, the resistance, work of breathing, surface tension, and time constant. So coming to one by one, compliance is a measure of the change in volume for every change given for every change in the pressure. So for a particular amount of pressure you give to the lungs, how much change in the volume of the lungs happens. That is a compliance. So if you imagine a balloon, if you blow air into the balloon, the amount of pressure needed to inflate the balloon is the compliance. The balloon is stiff, it needs more pressure. balloon is not very stiff, it easily inflatable. It also depends on alveoli as we look into pathophysiology of the neonates. So if we have a surfactant deficient lung disease, obviously the compliance is going to be very, very less because of the increased surface tension. The lungs are tending to collapse, they're very, very stiff. Similarly, if you have a severe congenital pneumonia, severe meconium aspiration, where the lungs going into atelectasis. So the increasing the surface tension of these lungs causes increasing the compliance. Okay, the more stiffer, the less the lungs are compliant. So if you divide the compliance into two parts, the lung compliance, sorry, the chest compliance, which is as I said before, the newborn chest is the muscles of the diaphragm are not very, very stiff. So that means the compliance is easy compared to adults. So even the small change in the pressure, as you can see, the compliance of the lung capacity, the lung capacity can go up just because of the chest wall compliance. But if you look at the lung compliance, so it takes a lot of pressure from there to here to reach this peak pressures, peak volume. Yeah, this is the lung curve. Combination of this chest wall compliance and lung compliance is a total compliance that we are dealing with. So whenever we are dealing with the baby needs ventilation, we need to address both chest wall compliance and lung compliance. So for example, you are dealing with a baby with severe meconium aspiration and PPH. So you address the lung compliance by different modes of ventilation, trying to open the lungs, and also giving surfactant for these babies. Same time, if we can relax the muscles more and more by giving muscle relaxation, the chest wall compliance can also be increased so that effectively the ventilation can get better. So when you think of compliance, think about compliance of the lung and compliance of the chest wall. So normal newborn lung physiology, the inspiration phase. So the change in the pressure, this is the pressure on the x-axis and volume on the y-axis. Every unit change in the pressure, there's a change in the volume of the lungs. So as we can see in the first initial part of the inspiration, it takes a lot of time for it to reach and the volume to start going down and then starts peaking and then comes back again to expiration. Bit more explanation into this curve. I think it's a repetition of the last time. Mainly if you're dealing with a lung which is already atelectasis, so already collapsed lung, like a balloon which is completely collapsed. You're trying to open the balloon up, as you all probably know. When you're blowing, the initial part of the balloon is going to be difficult. So when you are trying to open the lungs for the first time, if you're not providing if you're preventing the lung from coming back to this atelectasis phase, you can do the ventilation much better. As you can see, the initial 1.5 pressures, only one change in the volume. But next half or one change in the pressure, the volume has gone up from threefold. So normal, generally, once your lungs are opened, the base part where the atelectasis part of the pressure volume curve, it is very, very low compliant lungs. So it takes a lot of pressure to open the lungs up. Once it reaches a particular phase, as you know, the balloon opens up easily. That is the good compliance. Again, once it reaches the limit of the balloon, so it means the over distension. Once the over distension particularly happens in babies with BPD, meconium aspiration with air trapping, all these babies. So the increase in the pressure in this area, there's not much increase in the volume of these lungs. So that is again coming into low compliant. So either we are dealing with over expansion or atelectasis. The compliance of the lung is not very good. So we should try and ventilate the baby in this area where the compliance of the lungs are very good. So which means by giving a just minimal amount of pressure, lungs can be opened up. So how do we do that? So to prevent the lungs coming back into the zero phase of the volume, you're trying to preserve what you call FRC, functional residual capacity. Functional residual capacity can be achieved by providing positive and expiratory pressure, the PEEP or the CPAP, whichever you call it. So the PEEP or CPAP preserves the functional residual capacity. As you might already know or practicing in your own units, over the last decade, previously, like when I was a registrar, we used to use to ventilate every single premature less than 28 weeks. Now, with the good use of delivery room CPAP, we are able to avoid ventilation for these babies because by reserving the FRC, we are allowing the baby to come into this part of the pressure volume curve where the breathing of the baby is quite easy for it. So by preserving the FRC, which can be achieved by CPAP or positive and expiratory pressure, and also next option would be the surfactant, administration of surfactant without ventilation by inshore techniques. So preferably delivery room CPAP and PEEP, and early surfactant if needed, prevents high pressure ventilation for these newborn infants. So just a schematic representation, as you see the baby with severe surfactant deficient lung disease, the lungs are very stiff, the compliance is very, very low. So it took almost 18 pressures for the lungs to start opening up. And even with the pressures of 30 to 35, the volume we achieved is only 1 ml per kilo. Look at the normal newborn lungs, by even just by 10 pressures, by the volume has gone up to 2 ml per kilo or even 3 ml per kilo. So it is important for us to prevent coming back to this atelectasis phase. Coming back to the overexpansion or beaking. So if you're over-distending the lungs, particularly if you're giving too much pressure without checking the volume of the lungs, without monitoring of the X-rays of these babies and chest expansion, there is a risk that you are over-expanding these lungs, which can cause more and more damage, both by increased over-distension, which can cause, it itself can trigger the inflammatory process and leading into chronic lung disease, and also high pressure needed to open the high pressure to achieve that over-distension. These two things are not very good for the baby. So preventing atelectasis and over-distension is a target for neonatal ventilation, where we need to understand, look at the machine, look at the baby, and look at the X-ray possibly if needed to make the adjustments to provide the minimalist pressure and volume to achieve the adequate oxygenation and CO2 clearance. Next, coming into the resistance. So the first part is the compliance we talked about. The next part is the resistance of the lungs. So the resistance basically means the two parts in the resistance of the lung tissue and the resistance of the airway. The resistance of the lung tissue, which we can't physically change much by the ventilation, but it is affected by the viscosity of the lung tissues. The more premature the lungs are, more atelectasis, the small bronchioles are more and more collapsed, more resistance to it. And lots of interstitial fluid that also causes lung tissue resistance to go up. Airway resistance, which is mainly the airway from the nose to the tip of the internal bronchioles into alveoli. The space, the flow of air through this air passage from the trachea, bronchi, bronchioles, and terminal bronchioles. As you know, the size of the airway is getting decreased and decreased. Every 1 degree change in the diameter or radius of the airway, there is 16-fold increase in the pressure required to deliver the same amount of volume into the lungs. So if you can imagine, if you are ventilating a baby, the size of the ET tube does matter, changing from 2.5 to 3 or 3 to 3.5, increasing the resistance, increasing the diameter of the ET tube by just 1-fold, you can decrease the pressure required by almost 16-fold. At the same time, you have to make sure the appropriate ET tube is inserted, which should not cause pressure necrosis. In newborn infants, we tend to use uncuffed tubes because to prevent pressure necrosis for these people. So, and also one is the size of the ET tube you decide and the length of the ET tube. So once the baby stabilized ET tube position is checked, please make sure you trim the ET tube to decrease the size of the ET tube, so decrease the resistance overall. So if you are trying to provide ventilation for these babies through this resistant lung tissue and airway, if the lung tissue is a problem, which means the pathophysiology is at the alveolar level, high viscous resistance lungs need high inspiratory pressure. So pressure is the one thing that's going to make difference for the expansion of these lungs. But if you're looking about the high airway resistance lungs, it's basically the inspiratory time and expiratory time that decides the amount of flow going in and out of the lungs. It's not the pressure, it's the time. So if it's a lung tissue problem in the resistance, it's the pressure. If the airway is the problem, it is the time. Next comes to surface tension. Surface tension is basically refers to elastic recoil to the tendency of stretched elements. Basically, the main contributor of lung elastic recoil in the newborn is surface tension. So as soon as we inflate the lungs has to come back deflating. So what pulls the lung back is the surface tension. The tension that pulls the lung back into expiratory phase is surface tension. Basically, as you can see, the Laplace relationship describes the pressure required to counteract the tendency of the bronchioles and terminal space to collapse. So by providing the pressure to prevent that collapse, you can prevent the atelectasis phase of the lungs. So by increasing the surface tension, the pathophysiology, if you have increased surface tension, that means the lungs are more stiffer and you have more pressure to open the lungs up. If it is by decreasing the surface tension, by giving external surfactant if needed, you can easily open the lungs with less amount of pressures. Next comes to the work of breathing. Work of breathing is proportional to the force generated to overcome both the resistance and elastic forces. Okay, it is a product of pressure and volume. So if you look into this curve, so this is the pressure, this is the volume. In the inspiratory phase, this is the pressure that's increasing the volume as the atelectasis phase and the overdistension phase. The areas between this part, okay, A, B, C, A, what we call. This represents the inspiratory work of breathing. And the area between these two will cause expiratory work of breathing. For example, if you have a stiff lung, that means the compliance is going to be low. So the curve will be like this. Okay, curve will go like this, in which case you need more pressure to open the lungs up. And also the expiration also can be prolonged. Okay, so again, coming back to that one single point, the compliance is one important thing. When think of compliance, think about the lung compliance and also chest wall compliance. Compliance, resistance, surface tension, which indirectly determines the work of breathing for this patient. Time constant. The last terminology I'm going to stress is a measure of how quickly the lungs can inflate or deflate. The simple terms. Basically, the amount of one time constant of the respiratory system is defined as time it takes the alveoli to empty 63% of the tidal volume through the airways to the mouth or ventilator. So by the end of 3 time constants, 95% of tidal volume is empty from the lungs. So time constant is important for us to know how much time is needed for this particular lung to open with the given amount of pressure. So if it is a stiff lung, again, you need longer eye time to open the lungs up, the same amount of pressure. If it's a good compliant lung, even the shorter eye time, you can open the lungs up easily. So the amount, one time constant is important for us to understand, because when we are setting up the ventilator, you need to decide about the inspiratory time and the expiratory time of the breath. Okay. I think so far it's clear. If anyone wants to ask any questions, I want to take 2-minute break. Or you can put in the chat box if you want to. Or shall I just move on? I'll see you 2 minutes if anyone wants to ask any questions. Okay, so going back, if I'm not getting any questions, either it is too boring or it is too clear or not understand. I don't know. So hopefully, I think I make. Okay, so someone is asking about the time constant. Time constant is basically the time needed, how quickly the lungs out, the time needed for the airflow to go in and out. Okay, basically it determines the expiratory and inspiratory time pattern that you want to set on the ventilator. Normally, one time constant is defined in the literature as amount of tidal volume, 63% tidal volumes to come out. Okay, so there is no specific time constant that you can use to set up for a particular baby. Okay, but while once I go to the modes of ventilation, probably I'll touch a bit more on this. It tells you, but determining the inspiratory time and expiratory time of the baby, you allow the lungs to open a particular time. For example, your time constant is too short. Your I time is too short, but time constant is long. For example, for these lungs need at least 30 to 40 seconds. 0.3 to 0.4 seconds for the lungs to open up. But you set a I time of only 0.2. Even if you give good amount of pressure and you have a very good ventilator, because you're not allowing enough time for this lung to open up, it doesn't open the lungs up appropriately what you wanted to achieve. So time constant is something, there is no specific specific normality for a particular baby. But if you want to set up a ventilator settings, the rough settings most of us use, when you look at the time, inspiratory time is equal to the gestation of the baby. For example, a 30-weeker, the I time I start will 0.03 seconds. Once you 0.3 seconds of inspiratory time, then you stand beside the ventilator, watch the pressure volume curve. Are we allowing enough time for this baby to achieve the volume? For example, if I go back to this curve, if I give only less time for this lung to open up, it might not reach this particular phase. It might just go there and stop. Okay, so by standing at the baby bedside after putting an inspiratory time, it allows you to understand what is the time constant for that particular baby. Hope it makes sense. Okay, so coming back to some terminology. Okay, so the normal terminology that we come across in conventional ventilation or on the different ventilators, or the PIP, the peak inspiratory pressure, which means the pressure that is required to open the lungs up. You are determining as a physician, you and me are deciding how much pressure we are giving for this baby. Okay, positive and expiratory pressure. So you want what's the pressure to be remnant in the lungs at the end of expiration. By providing the positive and expiratory pressure, you are trying to preserve the FRC, the functional residual capacity of the lungs, preventing the atelectasis. Inspiratory time, as I said, inspiratory time is a time taken for the lungs to complete the inspiratory phase. So again, inspiratory time and slope goes hand in hand. Okay, so inspiratory time, the time taken to reach the peak inspiratory pressure. Okay, that is the inspiratory time. And the rate on ventilator is rate of mechanical artificial breaths that you are going to give to the baby, or also the rate of mechanical breaths that are going to be supported to the baby. The slope for most of the new ventilators, the slope is auto adjusted. It basically tells you how quickly you want the peak to be achieved. So if you have a high flow, the same peak pressure can be achieved very quickly. Inspiratory expiratory ratio, indirectly by setting the inspiratory time and the rate, you're setting the inspiratory expiratory ratio. Most commonly used ratio is 1:2 or 1:3. Tidal volume is basically a common simple language to keep it simple. It's the amount of air going in and out for each breath. So normal tidal volume, we are targeting around 4 to 6 ml per kilo. So just going a bit more into out of these all parameters, which parameters affect the oxygenation, which parameters affects the carbon dioxide clearance, which means the ventilation. So the gas exchange at the alveolar level depends on the oxygenation, ventilation, and also the perfusion of the lungs. Going into oxygenation. if I take into this curve, okay, so this is the time, this is the pressure. So time pressure curve. So the initial first slope, the peak inspiratory pressure. This is the slope. Okay, this is the peak inspiratory pressure, that is 20. And as you can see, slope is slightly sigmoid, it's not straight. And the time from start of inspiration to start of expiration is the inspiratory time. Okay, and then the expiratory phase. This is called the pressure curve, the pressure against time curve. The area under this curve determines the oxygenation phase. Along with the FiO2, obviously the oxygenation can be changed by just giving the oxygen. But also we as physicians, we know too much oxygen is not good for the baby. Okay, so by adjusting the ventilator settings, you want to try and decrease the FiO2 requirement for this baby to provide appropriate oxygenation to the tissues. So what are the parameters that will affect, that can change the oxygenation of the particular baby? So if for me it's easy to remember, I say the area under this curve that changes the oxygenation. So if you can increase the, if you increase the peak inspiratory pressure from here to there, the area under the curve is increasing. If you increase the slope from here to there, okay, or you want to have prolonged eye time, or you want to increase the peak. That means the slope, peak inspiratory pressure, inspiratory time, and peak and expiratory pressure. All four parameters can influence the oxygenation part along with the FiO. Yeah, makes sense. So how do you adjust this on the ventilator? PIP can be adjusted directly by increasing the peak inspiratory pressure, PIP settings. The PEEP can be increased by PEEP settings. Eye time can be, inspiratory time can be changed by inspiratory settings. And the slope can be adjusted by the flow. Okay, the new ventilators, it doesn't let you adjust the flow that much, but there is an option to select whether you're going into a sigmoid pattern or you want to go for the square pattern. Okay, if you're going square pattern, you have more area under the curve and you have more oxygenation. So providing the square shaped curve, you might be able to decrease the FiO2. But at the same time, you have to remember you are exposing these lungs to the longer time for the peak pressures. That can also cause damage to the lungs. So it's a balance of things. Adjust peak inspiratory pressure, positive and expiratory pressure, inspiratory time, and the flow along with the FiO2 that affects the oxygenation. Next one is the ventilation. The CO2 removal, the carbon dioxide removal is mainly dependent on minute ventilation. Minute ventilation is defined as respiratory rate times tidal volume. Okay, so again, the respiratory rate depends on the inspiratory time and expiratory time as you adjust. Tidal volume is depend on the main airway pressure. So it's difference between, if you go back to this, the amount of air goes in and out between this peak inspiratory and peak positive and expiratory pressure. So by adjusting this place, you can adjust the ventilation. Okay, so by changing the PIP and the PEEP, you can change the tidal volume. By changing the inspiratory time, you can change the respiratory rate. By these two things, you can change the CO2 removal. Okay, so if you're making a change in the PIP or inspiratory time or the peak expiratory time, indirectly you are affecting both ventilation part and also the oxygenation part. But if you're keeping TI constant, PIP and PWP constant, only changing the respiratory rate, which means the expiratory phase of the ventilation, you are changing only ventilation but not oxygenation. So if you don't want your oxygenation to be changed, but only CO2 clearance to be addressed, better to go for the respiratory rate. If you want both oxygenation and the ventilation, which means the CO2 clearance, to be adjusted either to increase or decrease, you target these two settings commonly, peak inspiratory pressure and the positive and expiratory pressure. Next concept I want to probably quickly for you to understand with the dead space. The two types of dead space we say anatomical dead space and alveolar dead space. Anatomical dead space, the total volume of the conducting airways from the nose or mouth down to the level of terminal bronchioles. This part of the airway is not available for gas exchange. Okay, so it is important for us to know how much dead space is there. Roughly 1.5 ml per kilo, whatever we are giving to the baby is not actually reaching the alveoli. It's only in the dead space. Along with that, we have instrumental dead space. Instrumental dead space means the ET tube, the ventilator tubings, depending on where you put your flow sensor and where you are measuring your flow and peak pressures. So if you imagine a 3 kilo baby, for example, you want to deliver a 5 ml per kilo tidal volume. Okay, so you're setting a volume, you're targeting a tidal volume about 15 ml roughly, 5 ml per kilo, 3 kilo baby, 15 ml. Plus you have an instrumental dead space roughly to 2 ml per kilo. I take sorry, respective is it's not depending on the kilos, roughly around 5 ml I say. So 20 ml total dead space for this baby. So on top of it, the amount of the flow that needs to go into the alveolus is more than 20 ml should go in to reach the alveolus. Okay. For example, the same thing you take to 1 kilo baby. Okay. 1 kilo baby, 5 ml per kilo is 5 ml, and your instrumental dead space is still the 5 ml. So the smaller the baby, the instrumental dead space becomes more and more important for us. Okay, because you're adjusting per kilo basis, but instrumental dead space you're not adjusting per kilo. It's constant whether it's a term baby or a preterm baby. Okay, so it's important for us to adjust our instrumental dead space by providing the flow sensor and where you measure the pressure as closer to the baby as possible and as shorter ET tube as possible to provide to decrease the dead space. And also another thing, alveolar dead space basically depends if you have under perfused alveoli, under atelectasis alveoli, where the amount of the airflow is not reaching the alveolus. Effectively, the physiological dead space is a combination of anatomical dead space plus alveolar dead space. So for you to just keep in mind whenever you're adjusting the ventilation, if your baby is not behaving in a way what you expect it to do, think about dead space. Is it contributing to the ventilator parameters that you're adjusting? Okay, hope that makes some sense. So oxygenation, ventilation, and then dead space. I'm just going to the next thing is modes of ventilation. Anyone ask any questions before I move on?
Dr. Ranjit, should we keep modes of ventilation for the next session on Thursday, or should we continue? Because we have 10 minutes left in the meeting for this presentation.
It does take at least half an hour. So.
Okay, so let's keep it for the next meet. That will be better.
Okay.